Hi students, let us look at questions from NEET PG in 2022 exam. And what I got from the questions is most of the questions were doable. Most of them we had discussed in our class notes and the TND notes. In fact, few of them are straight repeat from the questions that were given to you in the class test GT and the SWTs as well. And let's look at question number one. Question number one, which of the following is not seen in men to be? In fact, this question I had asked in one of the in your SWT. Of course, it was more a complex question where I had given you lengthy one with the help of other things. So, men to be will not have parathyroid adenoma. Parathyroid adenomas or hyperplasias, these occur in men to A, not to B. So it will occur in men 2A, and we have discussed this. A RET mutation will happen in men 2B, and there's a gain of function mutation of RET happening, and that is leading to these type of mucosal neuromas. Then there will be and now there is some query regarding this. Many people have asked, will megacolon be seen? Answer is absolutely yes. Megacolon is seen in men 2B. Megacolon is because of there is reduced tone in the colon, and this reduced tone in the colon is because of either ganglioneuromas which are seen, mucosal ganglioneuromas, or it could be even because of catecholamines secreted by the pheochromocytoma, which is also associated with men 2B, right? Yes. Next question. This question we have discussed it so many times, and I'm sure everybody has got this. Why does cancer cell undergo Warburg effect? So we understood this already. You want to use glucose for synthesis of the nucleotide, the DNA, and some amino acid, basically the cellular building purpose. So option B, useful to make intermediaries for survival. I would have seen it is better for replication, not for survival, for replication. That is what is Warburg effect doing. Increase in ATP? No, it is not increasing in ATP. Because of Warburg effect, there is a decreased ATP production because there will be aerobic glycolysis happening, and it is not anaerobic, remember. So there will be no lactic acid production here. To avoid aging and remain immortal, this is not because of Warburg effect. This can be because of gain of function mutation of telomerase. Sometimes there will be telomerase mutation, the enzyme gene for telomerase, that can be there. Telomerase mutation, some of the tumors like pancreatic carcinoma, etc., will be having that. Less glucose uptake by tumor cell. Yes, this is a true statement, but that is not why do they undergo. So because of Warburg effect, there is a there will be no less glucose uptake. There will be increased glucose uptake. Less glucose, less ATPs are produced. There will be not less glucose. There is increased glucose by the tumor cell. That is because of Warburg effect. Yeah. The next question 3, true about aging and senescence is. So this question I've got varied recall things in this, that whether it was asking about aging and senescence or just aging, because there were two questions on aging per se. That is why. So this one, let us see, aging and senescence. This was more of question on telomere and telomerase. So I've got three options recalled correctly. The fourth one, I do not know what was that. Okay. Telomerase activities increased in aging. So what is telomere? Telomeres are the ends of the chromosome. If they reach a critical, chromosome reach a critical size, because every cell division there will be, the telomeres become shorter and shorter. We all know that. And once it becomes into a critical size, there will be no more cell division happening. So, that is why cells have a capacity to multiply. It is not infinite capacity. They have finite capacity to multiply. And what will telomerase do? Telomerase is enzyme. So telomerase is an enzyme which maintains the length of the telomere. So it keeps adding the nucleotides to the telomere so that the length is maintained. So basically, what was telomerase do? Maintains telomeres. It maintains telomeres, And if it maintains telomeres, there is no more shortening of telomere. Because of no more shortening of telomere, there will be the cell will can multiply. So telomerase will activity decreases with aging is a true statement. This is a true statement. Telomerase activity decreases with aging. In fact, telomerase activity is increased where? It is increased in all your stem cells can have this. Then all the fetal or embryonic cells will be having this. And also tumor cells can be having that. So telomerase increase can be seen in stem cells, fetal or embryonic cells, and in tumor cells as well, right? Yes. So when aging happens, that means the telomerase activity will be reducing. Because of that, the telomeres will shorten, cells cannot multiply, and that is what is aging going to happen. This question we have discussed so many number of times, and in the class as well. Which of the following will result in chain termination by introduction of stop codon? So which mutation introduces stop codon is nonsense point mutation. So nonsense will introduce stop codon. Missense will be what? One amino acid altered, right? Point mutation, silent mutation will be no amino acid altered. So it will be same protein. And all these three, the A, B and D, all three are coming under point mutation, right? So yes, nonsense is a type of point mutation, missense is also type of point mutation, and a silent mutation is also point mutation. Next question, which of the following is autosomal recessive in inheritance? This was the easiest question, I guess. Cystic fibrosis. We studied this cystic fibrosis. It's an autosomal recessive disease in which there is a problem with your chloride channel, CFTR, isn't it? Yeah. So we studied this in respiratory pathology, where cystic fibrosis. The other ones, achondroplasia and other. So okay. Anyway, the option has repeated here. So anyway, whatever is the answer will be option B here, cystic fibrosis. Next. Question 9. Let us not 9, 6. Sorry, question number 6. This question there is I want your feedback on recall. You can send your feedback on my Telegram as well. So you can just search @Sanjeev Chitrakar. So this is my Telegram ID. You can personally message me this, or you can join a group. My Telegram group says path logic. You can just search path is equal to logic. This is the Telegram group. You can join this group and you can put what exactly is the recall in this, because I've got two different types of recall based on that, and both of them giving different answers. Okay, 9-year boy presented with history of recurrent chest infections was given, abdominal pain was given, had transfusion in the past. So chest infection, abdominal pain, and transfusion in the past. On examination, he had splenomegaly. This was also given, and icterus. See, the moment we see icterus, we are suspecting, and especially in a 9-year, and transfusions in the past, we are suspecting of a hemolytic anemia. Abdominal pain can happen in a hemolytic anemia, possibly due to gallstones. One of the common cause is gallstone. We had in fact had one question on sickle cell where there was abdominal pain and recurrent infection, and I had given a peripheral blood smear in our subject wise test. Anyway, let us look at this. Now this is where is the keyword which examiner had given. Investigation shows peak in S window is what I have got. Some people said me it was S and HbA2 is increased. Both of them have been given. I do not know. So if what about HbA2, that will decide. See, S window will have HbS, hemoglobin S, that we know that. So on electrophoresis, if there is only S window, that means only HbS is there. That means it's a homozygous condition. If HbA2 is also there, so we all know HbA2 is elevated in thalassemia minor, right? Yes. But however, I want to give you one important fact here, although not expected at your level. HbA2 and HbE, hemoglobin E, both of them are having same HPLC properties. That is why HbA2 will also elevate or HbE will also elevate a HbA2 window. So if it is only S window, single spike in S window, then answer will be HBSS as I have given here. But if it was given both HbA2 and HbS are elevated, that means I am now assuming it is a HbE and HbS, and we all know HbE is 26th position, glutamate to lysine is HbE, isn't it? Yes, is a HbE. That means this will be a HbS variant in that case. So now depends upon what was the question. If only S window was given and HbA2 was not elevated, then answer will be HbSS. Otherwise it will be a compound heterozygous condition where patient will be having both HbE and HbS, and this is what is your variant of HbS. So that is what is the answer to this question. So as of now I'm not sure what is it, but most of the students said it there was no HbA, that is why I am going with HbSS here. If HbA was there, then it will not be actually HbA, it will be. So if just to mention you guys here, you need to understand HbA2 levels less than 3.1 is normal, less than 3.1 is normal, and HbA2 between 3.5 to 9% is thalassemia minor. HbA2 levels more than 9% is considered as hemoglobin E. And actually if it is more than 9 to 50, it is heterozygous hemoglobin E. More than 50, it is homozygous hemoglobin E, right? Yes. So this is what I didn't expect this question at your level. Looking into the question paper now, I am very clear for sure this paper has been set by AIIMS people only, right? Okay, I'm very clear about this paper. This paper has been set by AIIMS faculties. I know because this is how they ended up setting the question papers. A woman, okay, next question. A woman presented to OPD with fatigue. Routine CBC shows hemoglobin 9 gram per deciliter, MCV 60, RBC count 5.2. We had discussed this, very important. In fact, I had a heated argument with one of the student in Delhi. If you can remember that student, Gautam Nagar student in the last TND that you had, Gautam Nagar Delhi batch. Exactly the same question I had given. Only difference was my RBC count was 6 million and my MCV was same 60 only, or 66 I had given, doesn't matter. So we had discussed this and I had given it as a 25-year female pregnant woman, and I had asked what is the next line of management. I had asked should you start oral iron, or we had a lot of debate. So whenever you get a microcytic hypochromic, the student was telling we have to start with iron. I said this patient is having a Menzer index. What is a Menzer index here? RBC count, MCV divided by RBC count. So MCV is 60 divided by 5.2. It is approximately some 11 point something, or we can say it is approximately 12. It is approximately 12. Doesn't matter what is the value, it is less than 13. I am suspicious of thalassemia minor. I am suspicious of thalassemia minor. I have to screen for thalassemia minor. That is why I do HPLC, or HbA2 will be the investigation here. That will be the answer. Okay, yes. So this was again a repeat question straight away from your TND, and also this question I had given in class test as well. This I had shown this so many times in the class, and also we had given in the test. Simple one. Patient presents with hemorrhoids and fatigue. Peripheral smear is as shown. What is the likely diagnosis? Now some people are confusing. This hemorrhoid history was there with the previous one, I do not know, or was this a separate question, I do not know. Anyway, so this patient is, now this is your microcytic hypochromic with, this is your pencil shaped RBC. So you had this pencil shaped RBC. Diagnosis here is IDA, iron deficiency anemia. So that is the answer to this question. So microcytic hypochromic anemia with pencil shaped RBC is given in the image, iron deficiency anemia. This question, the simplest one, again very simple one. We had discussed this in class a number of times. 45-year-old male, whatever is the age, 45, 55, same, no problem. Abdominal pain was there. Examination, he was found to have palpable spleen. Peripheral smear shows leukocytosis. Leukocytosis is there on peripheral blood smear. and there is increasing in basophil. We had mentioned this very clearly. Whenever basophils are increased in the blood, start suspecting query CML. That is what you're going to suspect. CML is what you're going to suspect. And myelocyte metamyelocytes are increased. Basically, there is a shift to left which happens. Translocation 922 will be the answer. Which of the following will be seen? 922. 1517 is seen in AML M3. We studied this also. 122, okay, 119 as such. 122 not a very important one. 119 can be seen in ALL. 1114 is seen in mantle cell lymphoma. Some people told it was 814, that will be seen in Burkitt lymphoma. Doesn't matter. So what was the option given there? Next, this question was more of applied question. Let us see what is the question. A 10-year-old boy presents with pain in the bone and bone shows sclerotic changes. Peripheral blood smear is as shown. Most common organism implied in osteomyelitis of this patient is. So that is what is the question. Looking at this, what are these? These are your sickle cells. So there were sickle cells that were there, and salmonella is the most common cause of osteomyelitis in sickle cell anemia, right? Now, and this we had studied in orthopedics, I'm sure, and sickle cells is where we had studied in pathology basically. So this was your applied between path and ortho. Now this question, I have a little bit, I have two types of people asking me. One set of student told me that it was this image. Another student told me that there was a spherocyte. So now it depends upon what was the question exactly. A patient presented with jaundice, elevated bilirubin, peripheral blood smear is as shown in the image. Which of the following is associated condition, they had asked. So in this image, what I have taken here, this is your schistocyte. Schistocytes are fragmented RBCs. Fragmented RBCs are seen if there is a physical trauma. Physical trauma could be like artificial valves or can be a MAHA. So microangiopathic hemolytic anemia, that is one. So some people said there was a spherocytes that were seen. If spherocytes were seen, then the answer will change. So physical trauma can happen because of MAHA or even because of a prosthetic heart valves. And one of the option given was mechanical second heart sound, usually will be seen whenever you are having a prosthetic heart valve. So that will be the correct answer for this. Next question, let us look at this. This was a straightforward question you would have definitely made. 26-year-old male presents with dyspnea, unconscious for 2 days after a road traffic accident, likely diagnosis. So there is a dyspnea and unconscious is there. So nothing more has been mentioned to you, and the key word here is dyspnea in the patient. So dyspnea in the patient makes it fat embolism. After a road traffic accident, there can be a injury happening to the long bones, and there can be a fat embolism that can be happening there. Next question, this was one question which we had discussed. Actually, this is a repeat question from previous year paper kit. If you have looked at in 2020 in INICT, they had given similar image that asked what is the investigation also there also, and similar question, and that's why I'm telling this is a repeat from this question paper was definitely set by AIIMS people. So in 2020 NEET INICT, this question came. We had discussed in detail that time. Apart from that, we didn't discuss it in class because not a very important investigation at the undergraduate level. Which a patient has intraoperative bleeding. The following is an image of intraoperative test done. Which of the following is a test that is done? So something like this, not exact same image. What is the investigation? Investigation is thromboelastogram. TEG is one. So TEG is a substitute for your PT APTD coagulation test, and now since they have asked it twice, we'll just discuss this a little bit more now. So what is happening in TEG? There are most important patterns of TEG. Let us start understanding. So most important patterns of TEG. Okay, so in TEG we will not get into the details as of now. You can just refer it from the previous year questions in discussion as well, you'll get about TEG. So the normal pattern is like this. There'll be one line that'll be coming, and actually in TEG you'll end up getting like this. So basically this is your graph that will be there. So in this part, the first part will be your initial platelet aggregation, that is the primary plug. This is your secondary plug. This will be your fibrinolysis part, right? So fibrinolysis part, that is how it will be there. Actually those three parts are there. So normal, it looks like this. Imagine like a wine glass, tall wine glass, but with a short handle. That is what is your normal. If there is any factor deficiency, it will not distinguish extrinsic intrinsic factor deficiency or anticoagulation like heparin, etc. The same will have a prolonged time in your initial clot formation. Now look at this, clot formation time has a prolonged here basically, right? That is your factor deficiency. Next, one more is hypofibrinogenemia. If fibrinogen is less, then how does it appear? If fibrinogen is less, then your primary plug formation will get little bit prolonged, but this part, that is your secondary plug, will be prolonged more. That is what is your afibrinogenemia. Then hyperfibrinolysis will be like a leaf shape, hyperfibrinolysis. And hypercoagulation will be the thickness of your what do you call, the TG increases. So this is your hypercoagulable state. So just remember these important few patterns that are seen in TEGs. Yeah, so let's look at the next question here. Next question was also about aging. There was one more question about telomerase and aging we discussed. Which of the following is a method to delay aging process? So they had asked this, how can you delay aging process? If you remember, we discussed this in autophagy in the class. So autophagy is going to eat its cellular content and prolong the lifespan of the cell. And when will autophagy get? Starvation. We were talking about this starvation, and I gave so many examples, including wild dogs and pet dogs. Pet dogs have a lesser lifespan because we feed them more, and that's why they're more calories, they die early. And also I gave you examples, I think, of the upvas or the rat that is kept in both all traditions of all many religions, which is ultimately making you fast so that you end up having your prolonged. So answer is calorie restriction. Calorie restriction will end up leading to prolonged lifespan of the cell or delayed aging of the cell. So again, this was discussed. Next question, this was one of my favorite topic. I have asked so many questions in your all the tests whichever you'd have given. All of the following are true about NET except which is false has been asked. Seen in sepsis, it's a battle between neutrophil and bacteria, releases antimicrobial products, mitochondrial DNA is involved. So we all know that this is the false statement here. So mitochondrial DNA is not the involved, it is the nuclear DNA. So remember, it is not mitochondrial, it is a nuclear DNA. We discussed this nuclear DNA, which was a long thread, forms a chromatin meshwork. That is what is your NET. And will there be antimicrobial? Yes, it was made up of DNA, it was made up of enzymes, which will be antimicrobial enzymes, tissue destructive enzyme. So only one thing is, what is the role of your NET? NET is protecting against deep infection, but if NET happens more, then more tissue destruction will happen, and more tissue destruction can lead to sepsis also. So answer to this question, which is not true, is mitochondrial DNA is involved. That is not true here. That is not the that is the answer. Next, so next question, again we discussed this in class. 12-year-old boy presents with diarrhea and associated with HLA-DQ2. If you remember, we had discussed diarrhea with HLA-DQ2 and DQ8 also is celiac disease. And treatment for celiac, low gluten or gluten-free diet. That will be the answer for this question. Right? Yes. So next question, again, this is I got confounding questions in this. Just check if it is the correct one. A 10-year-old boy presents with, some people said it was not 10 years, some people said it was 20-year adult. So it depends now. If the age has been changed, then it is totally different. Presents with periorbital edema, albuminuria, hyperlipidemia. May not be the exact words, but all these things were given. Edema was given, albuminuria was given, or hypoalbuminemia was given, I guess, and hyperlipidemia. A diagnosis of minimal change disease was suspected. So this is, I do not know, recall, or a diagnosis of nephrotic syndrome was suspected, whatever was word was given. True about this condition. So if it is a 10-year-old boy, we are suspecting definitely minimal change, right? If it was a 20-year, then FSGS is what we are suspecting. So now it depends upon what was the age given. Effacement of food processes is seen on light microscopy. Was this in the option? Again, now it depends upon, if it was 10-year, then light microscopy anyway is false. Wherever it is, it will be seen on electron microscopy. Okay, so that will be anyway false statement. So question asked is true. Will effacement be seen in both FSGS? Yes. And even in minimal change disease? Yes. But on electron microscopy, not on light microscopy. So either FSGS or adult or children, this option, if it was light microscopy, if specifically given, then wrong. If they had just mentioned effacement of food processes is seen, that will be true for both FSGS as well as minimal change. Non-selective proteinuria is a false statement again for minimal change disease. Non-selective proteinuria can happen in adult FSGS, adult form of nephrotic. In childhood, there will be specifically selective proteinuria will be there. And response to steroids, this will be true statement for minimal change. If it is a FSGS, this will not be as good responsive as minimal change. Common in adults, minimal change will be false. So now we have to look which was the question. If it was adult, then it will be FSGS. Then answer would change. Respond to steroids will be false statement there. True statement would have been very common in adults. That will be the best answer there, I guess. So what in this I have taken it to be 10-year, minimal change, and respond to steroid. That is the best answer for this. So it depends upon what was the question. I've got two confounding or conflicting questions that are there here. Next question, let us look at this next question. Okay, there is no confusion regarding this. Maybe here and words. Okay, 25 years, some people said 35 or 40 year, that is okay. Presented with history of oral ulcer, arthritis and rashes. So there were rashes, arthritis given. On routine examination, RBC was found in urine. So simple, RBC was found, and was RBC cast also given? I do not know, but anyway doesn't matter. For me, this is more than enough. Rashes are there, arthritis is also there, and RBC in urine. So this is suggestive of glomerulonephritis. Anyway, options are glomerulonephritis. Is it cystitis? No. In cystitis, you would not have been finding all these things, right? And this possibly query lupus. That is what I am suspecting, because rashes can be seen in lupus, arthritis can be seen in lupus, ulcerations can also be seen in lupus, and of course glomerulonephritis. Not a PSGN. Why? Because in PSGN there will be no arthritis happening, there will be no rashes happening. In PSGN only sore throat will be there. Acute interstitial nephritis is also not the answer. Usually in interstitial nephritis, it will be a tubulointerstitial nephritis, which is mediated by drugs mostly, and eosinophils will be there in the urine. Answer is lupus nephritis. That is the answer here. Next, 19, question number 19, whether the image was same or not, I don't know, but history was giveaway here. Okay, 45-year-old man present with history of fever, recurrent episodes of cystitis. So fever itself tells it is infection is happening. Yes, there is an infection, and cystitis is happening. So of course there is an infection and inflammation of the bladder. Biopsy from the bladder is as below. What is your diagnosis? That is the question asked. So this is the biopsy has been done. Option, look at the option: acute cystitis, interstitial cystitis, malakoplakia, transitional cell carcinoma. So anyway, this is not a transitional cell carcinoma. I don't say any tumor cells here, right? That is not the answer. Answer here is malakoplakia. What is malakoplakia here? This is your Michaelis-Guttman body. So Mg bodies, what are Michaelis-Guttman bodies? Actually, these will be partially digested bacteria inside the macrophage, and on which there will be calcium and iron that will be present. Michaelis-Guttman bodies. So these are your Michaelis-Guttman bodies. These are Michaelis-Guttman bodies seen. Even this is also Michaelis-Guttman body. Michaelis-Guttman bodies are seen in Malakoplakia, commonly by E. coli infection. Chronic infection by E. coli and Proteus also can be causing. Now this again confusing options. So let me check what are the keywords here. A patient presents with multiple anogenital warts. I think there was an image given of anogenital wart only. And which of the following etiology increases the risk of anal squamous cell carcinoma or just squamous cell carcinoma? Whatever was the question. If this was mentioned, which increases the risk of squamous cell carcinoma. So two important things are there. Did they ask only genital warts? If only genital wart, mostly caused by 6 and 11. These are low risk. Genital wart are caused by low risk, which do not cause, they will not cause carcinoma. No carcinoma happens with them. However, if they have specified, then the high risk only. HPV 16 and 18 both can be causing high risk. This is HPV 16 and 18 are rare in warts. They are rare in wart, but however, they are the one which will cause carcinoma. So if this word was given predisposing or increasing risk of carcinoma, answer will be HPV 18. Otherwise, answer would be HPV 11. Most commonly 6 and 11, which are low risk, we call them, they will not cause carcinoma. Next question. Identify the marked structure below. So they have marked the structure and asked you to identify, and what you are seeing here, definitely I can see this part is some like this. So cells are like this, which will be more of what? Acini or glandular. So these are glands, or I can call them acini, and some parts don't have that. So these don't have that. So glands or acini, this will be exocrine part here, and options will give you the diagnosis. Now what is the option here? Salivary gland will not have such parts. So these acini will be present in salivary glands, that is correct, but not these other part. And marked structure is not the gland, right? And it is not the lymph node for sure. It is not even spleen, because there are no lymphoid structures seen here. Answer is islets. So this is the exocrine part of pancreas, and this is your endocrine part of pancreas. How do you identify exocrine and endocrine? Exocrine will be having acini or gland formation, and the endocrine will not have any gland formation. Okay, so probably the image was not the same, but anyway, you can identify this based on that. Next, one more question came. Biopsy from ulcerated lesion measuring 0.3 centimeter on the tip of the nose is as follows. Likely diagnosis. Again, is the image same? I don't think so. This was, I mean, I cannot be, I have not attended the exam, so I'll not be able to know exact image. But what you are seeing here is, I will tell you, there is an inward growth of, there is a mass that is happening, but the growth is inwards like this, not outwards, isn't it? Yes. And this is what is typically seen in your basal cell carcinoma. Basal cell carcinoma, we call it rodent ulcer, isn't it? Yes, rodent ulcer, and typical history has been given, right? So it cannot be squamous cell carcinoma in the nose. This is a triangle, right? Triangle of your basal cell carcinoma. That is it. Not melanoma, not nevus, right? Yes. So in melanoma, there should have been pigmented cells that will be present. Melanin should have been present. That is not the case. Next. This again we discussed this before and previously asked in INI-CET before. We had discussed that in PPI also. Patient was diagnosed of COVID-19, was put on ventilator, and later dies of this disease. So basically, the moment he was put on ventilator, that means he was having severe hypoxia, which will cause ARDS. So there will be ARDS happening because of any inflammation will cause ARDS. We had discussed this. Can COVID cause ARDS? In fact, yes, it causes ARDS. And what will you see in ARDS? You will see fibrin-rich hyaline membrane, isn't it? You are going to see hyaline membrane. And only thing is, it's not called hyaline membrane disease. Hyaline membrane is also seen in HMD, respiratory distress syndrome of newborn, which will have a fibrin-rich exudation. The pathogenesis is different here. Endothelial injury will lead to exudation. There it will be primarily surfactant secretion is reduced, which leads to hypoxia, which eventually leads to endothelial injury, and fibrin-rich exudation will happen there also. So this was your question. Fibrin-rich exudate. I think they should have given even, I do not know. Okay, inclusions definitely not. Viral inclusions are not seen in COVID. Apart from fibrin-rich exudate, this is your ARDS manifestation. ARDS manifestation. Apart from this, there can be even small thrombi seen in the pulmonary vessels. That will be seen in COVID-19 lung. Okay, next question was from, this also we discussed. Histological examination of thyroid lesion is as follows. All of the following are true about the lesion except. So there is except that has been given. And looking at this, you can see these are your orphan Annie I nuclei. Orphan Annie I nuclei, which are optically clear nuclei. So diagnosis is papillary thyroid carcinoma. So what is the question? FNAC cannot diagnose this condition. This is a false statement. FNAC cannot diagnose follicular carcinoma, right? Because for follicular carcinoma, we look for invasion. For papillary carcinoma, nuclear features are enough, and that is seen even on FNAC. So nuclear features are diagnostic of this lesion. Yes, that is true statement. It frequently spreads via lymphatic. That is also true statement. Excellent prognosis is also true statement. The only thing is, I think rather than thyroid lesion, they had given in front of the neck something, and age was also given, young age possibly, and that is true for this condition. That is your papillary carcinoma of thyroid. Next question. Okay, so image I'm not very clear, but looking at the option I can make a diagnosis here. Below is the image of testicular biopsy in a 30-year-old man who is being evaluated for infertility, and I think they had added one more. Semen analysis shows azoospermia. Of course, without azoospermia, we don't do a testicular biopsy, and usually FSH-LH should also not be elevated to do a testicular biopsy. So we will do test because it is going to be very painful. So testicular biopsy is indicated if there is any problem in the testis. So this is the biopsy that was given. Now options given were, look at the options. Then I always keep telling this, no, based on the option you can easily rule out. ITGCN straight away is ruled out. We are not suspecting a neoplasm at all. And in ITGCN, there should be proliferation and the cells should be in a neoplasia. There will be proliferation of the cells and everything will be occupied. Acute epididymo-orchitis. For orchitis, there should be inflammation present, and in the image, there was no inflammation seen, no neutrophil, nothing. Occasional 1 or 2 neutrophil, no, nothing was seen. And if there were many neutrophil, etc., you could have thought of orchitis. That is also ruled out straight away. Now, atrophy of testis and Sertoli-only cell syndrome. Now, these two were confusing. If there was atrophy, you shouldn't have seen any of these cells also here. So, there should have been atrophy of the cells happening. That is not the case here. So, that is also, I rule it out. Answer is Sertoli-only cell. So, just to tell you in testicular biopsy for future. So, in testicular biopsy, actually normal testis, if you remember, this will be your seminiferous tubule, and in between this seminiferous tubule, these will be your Leydig cell, right? These are your Leydig cell, and in the seminiferous tubule, there will be few cells like this. These cells are your Sertoli cells, which are more very little bit tall columnar like cells. These are your Sertoli cells. Sertoli cells are the supporting cells of the testis, and there will be other cells which having dark nuclei like this. So these are having dark nuclei. These are your spermatogenic cells. So these will be your primordial germ cell. So what will happen is they will keep maturing, and there will be what? So they will keep maturing, and ultimately you will end up seeing multiple cells like this in normal spermatogenesis, and ultimately in the lumen, near the lumen, you will see very, very faint appearing nuclei like this. These are your mature sperms in the lumen. This is your normal testicular biopsy. So few things I want you to understand here. Okay, there are, based on histological pattern, we divide the testicular biopsy into 6 things. One is a normal. Next, second is hypospermatogenesis. That means spermatogenesis is less. Third one is Sertoli only cells. That is most common cause of testicular cause of infertility. Most common testicular cause of infertility, Sertoli only cell. Then maturation arrest. Then sclerosis or nothing but fibrosis of testis. And mixed type is any of these mixed type. So basically these are the 5 different 6 patterns, mixed type included, 6 patterns of what do you call testicular pathology, not pathology. One is normal in infertility. So let me just try to show you the normal testis also. That is, normal testis where there is no infertility. Look at this. Let us try to identify the cells here. So this is one seminiferous tubule. I'm not seeing Leydig cell. If Leydig cell, they should have been somewhere here, right? So these would have been your Leydig cell. That is not the case here. Now look at this. In this, try to identify with nucleoli, the cells with nucleoli. So I am talking about such cells here. This cell is your Sertoli cell. So here there will be Sertoli cell. Sertoli cell. And I hope all of you are able to see these dark nuclei with various size of the cell. Obviously, why various size of the nucleus? Because of various stages of maturation. As you go inwards, they are becoming smaller and smaller. And these are actually becoming more and more mature sperms. And if you look right in the center, actually, so look at this. This is your, definitely this is your mature sperm that you are seeing. So more towards the center in the lumen, actually you start seeing what? Sperms. This is your normal testicular biopsy, just to understand what is a normal testicular biopsy here. Okay, yeah. So answer to this question was, so in hypospermatogenesis, what happens is you don't see these things. You see Sertoli cells. You'll also see the what do you call the spermatogenic cells, but less will be there. That is a hypo. Maturation arrest will be live. Okay, these will be there, and the sperm will not be seen. That is maturation arrest. So you will see the spermatogenic cells, but there will be no mature sperm formation at all. Right? That will be maturation arrest. Sclerosis, fibrosis will be seen. That is not the case even in the image that was given. So answer to that will be, by just ruling out, I will end up answering it as a Sertoli only cell. So I hope these questions were not, I'm sure they were not very tough. Most of the questions we have discussed in class, and if you had applied a little bit of logic, you would have got all questions correct, I would say. Because except for possibly only one question which I might doubt that you would have answered this, because just by ruling out the options again, only one question which I am not very clear about what was, it was this one, that is whether it was yeah, so only S window was given or HbA2 was given. Based on that it will decide. So only S window was given, HbSS. If A2 was given, I told you HbA2 more than 9% will be what? HbE. And that is why you will, in that case, you will end up calling it as a HbS variant. It will be a HbS variant. Okay. Yes. So that's it from my side. NEET PG questions. Give me a feedback on my group, and also if there are any questions I have missed out on the group, you can follow at the rate this is my personal Sanjeev Chitragar on Telegram. You can send me a personal message, you can just do this, or the group is at the rate path equals logic by Dr. Sanjeev Chitragar. That will be the name. You can join this, and we'll be having you can give me any other questions I missed or any options if they have changed. Okay, thank you.